lecturer there, Dr. Phelps, but really gives me a great pleasure to introduce Dr. Kevin Phelps for our monthly conference today. And it's really satisfying because I can remember when Dr. Phelps was an intern on the trauma service doing his residency here at CMC, but that also is just depressing because that reminds me how old I am. So after his residency here, Dr. Phelps went to Texas for an orthopedic trauma fellowship, and then we're very fortunate to have him back here as a really important player and important member of our trauma program here. So obviously we're all familiar with severe pelvic fractures. We see a lot of it, and this ought to be very informative. So Kevin, thanks for joining us. Really look forward to your presentation today, and hopefully we'll have some good questions as you wrap up. So thanks for being here.
No, thank you. I appreciate the opportunity to come and talk about this subject, which is near and dear to my heart. I have a special interest in this, and I love taking care of these patients and love doing these cases. And so hopefully we can all learn a little something today. So I'm going to be talking about emergent management of pelvic ring fractures. And first of all, have no disclosures related to this topic. As a little bit of an introduction, these are the kind of patients that we're going to be talking about. These patients that are in high energy motor vehicle, motorcycle collisions, have really severe pelvic ring injuries. And the goals of this talk are to get you to be able to identify these patients that are at risk for decompensation, identify the unstable pelvic ring that could be a problem with when you're resuscitating these patients. And you want to understand the initial management of the hemodynamically unstable patient with a severe pelvic ring injury, and also know your role in the process in taking care of these patients. So hopefully we should be able to cover all these things throughout this talk. So we'll start off with a case. I think there's, if you could just silence your mic there, somebody's mic's going off. I think I took care of it. Okay. We'll start off with a case here, 37-year-old female that was involved in an assault with another mic going off, involved in an assault with a hit and run, and she was run over by a car. So she presents with this pelvic ring injury. Obviously, this does not look like an anatomically normal pelvis. If you've seen a pelvis x-ray before, this is what we would term an open book pelvic ring injury, which we'll get into in a little bit more detail in a minute. But when you see this, you want to be thinking about some of these questions. First of all, what do you want to know about this patient? And then what do you want to do? What's your role in the management of this patient? Then also, should you be worried? And so as far as what do you want to know what their hemodynamics are. Are their blood pressures normal? Are they hemodynamically unstable? Are they crashing on the table? You want to know what their clinical status is. Do they have any other obvious injuries? Sometimes you want to know the stability of the pelvis. I think everybody would agree, looking at this x-ray, you can identify that this pelvis is unstable just based on the x-ray. This is not a pelvis that would need any sort of exam to determine its stability. It is an unstable pelvic ring injury. And then what do you want to do? The things that you want to think about doing acutely when somebody like this comes into the ED is you want to get a good exam, a good quick exam of the patient. And we'll go through that in a little bit more detail. But you also want to think about taking this volume expanding pelvic ring injury and decreasing the volume. So you want to decrease the space that's available inside the pelvis for blood to accumulate, decrease the volume. So what's your role? It really depends on what part of the team that you're on. Are you on the trauma team? Are you on the orthopedic team? Are you on the EMT team? Different people in those different arenas have different roles, and we'll cover a few of those throughout the duration of this talk. And should you be worried? Absolutely. A patient comes in like this, if they're awake and talking, they could be awake and talking 1 minute and then crashing the next and go pulseless with an injury like this. So this is a very, very severe pelvic ring injury, and this is what I would call a life-threatening orthopedic injury for most patients. So just quick fire, some facts regarding pelvic ring injuries. So the mortality rate is between 1 and 15%, can be upwards of 50% for open pelvic ring injuries, and also worse as patients get a little bit older. The leading cause of death in these injuries is usually hemorrhage. For lateral compression pelvic ring injuries, which we'll go through the classification here in just a few minutes, it can be a closed head injury, but most of these, especially the volume expanding pelvic ring injuries, will be hemorrhage, bleeding. Most common type of bleeding is usually venous. The arterial is what we really worry about most of the time as far as patients decompensating, but most of the bleeding is from venous sources in the pelvis. Common non-orthopedic injuries, head injuries, as we talked about, especially with lateral compression pelvic ring injuries, and then also urogenital injuries as well. Patients can get posterior urethral tears, they can get bladder ruptures, and a lot of these patients actually will have sexual dysfunction down the line once they have healed up from their pelvic fractures. They can also have neurologic injuries, nerve injuries coming out of the sacrum, L5, femoral nerve injuries, although those are overall not very common. So the thing to remember when you're looking at a pelvis is that it's not just the bony anatomy, which is what we see on the x-rays and the CT scan. There are a lot of really robust ligaments holding the pelvis together. So you have the sacroiliac ligaments in the back, the anterior and posterior ligaments, and you also have really thick ligaments at the caudal aspect of the sacrum holding the pelvis together. And then you have ligaments in the front of the pelvis as well, holding the pubic symphysis together. And so anytime you have a pelvic ring injury, always think about the ligamentous anatomy of what ligaments are disrupted in order for this to occur. And these ligaments are very, very strong and very taut. So it takes a lot of energy to disrupt these. Another thing you want to think about, as I'll show you here, these are what we call Judet films or iliac oblique and obturator oblique x-rays of just a normal pelvis. And what you want to think about is that in addition to the bony anatomy, you want to think about the vascular anatomy. So this is really what we worry about causing significant issues in these pelvic ring injuries is disruption of any one of these blood vessels. A lot of these blood vessels are very intimately associated with the areas that are fractured in the pelvis. And this is the arterial system, but you also have to worry about the venous system. As we said a minute ago, that approximately 80% of bleeding in the pelvis is venous in nature, okay? So keep that in mind. So think about classifying these injuries, and we'll put them into kind of broad categories, and it's mainly based on the mechanism of injury is the easiest way to think about these. So the first classification is lateral compression pelvic ring injuries. And these are when people get T-boned, they're sitting in the driver's seat, they get T-boned on the side, and the door intrudes and hits the side of their pelvis and causes this type of injury. You have Rami fractures in the front and usually a sacral compression fracture in the back. These are typically volume compressing pelvic ring injuries. Although sometimes they can, but usually these decrease the volume inside the pelvis. And you can even see on the x-ray there, on that central area that's lighting up is the bladder, and it's asymmetric in the pelvis, which is indicative of a hematoma that's likely compressing the bladder from the pelvic ring injury. And the thing to remember about these is they occur along a spectrum. And this is also true with the anterior posterior compression pelvic ring injuries that we'll look at. We classify these from 1 to 3, 3 being the worst, 1 being the not so bad injuries. A lot of times the ones are treated non-operatively. The 3s are the ones we really worry about. These are the ones where there's a lot of energy imparted into the pelvis. One side of the pelvis basically internally rotates and then hits the other side of the pelvis and causes the other side of the pelvis to externally rotate. So these can cause a lot of significant issues for patients. And again, they get more severe, more life-threatening, more risk for vascular injuries from lateral compression type 1 to lateral compression type 3. We then look at anterior posterior compression injuries, and these are volume expanding pelvic ring injuries. And I think that's an important distinction to make because these are the ones we really worry about from a vascular standpoint and a neurologic structure standpoint. So you can see on this nice diagram here on the left of the number of ligaments that have to be torn in order to get this type of x-ray here on the right. And again, these are along a spectrum. They can be just the symphysis disrupted, which is what we would call an APC type 1, to having every single one of the ligaments in the pelvis disrupted and a significant volume expanding pelvic ring injury to an APC type 3. And that's what this looks like. And it's just varying amounts of ligamentous disruption in the pelvis that occurs based on increasing energy that's imparted to the pelvis during an accident. And then we have a vertical shear injury. These are the people that fall from height. Maybe they fall out of a window or maybe they jump off of a bridge. You have vertical translation of the hemipelvis, and this can be a little bit of a combined mechanism because these can be volume expanding as well. But you also have that vertical translation component. And these are people that will oftentimes put in traction to pull the hemipelvis down into a more anatomic position before we try to think about closing down the pelvic volume. And as you'll notice here in the x-ray on the right, you can actually see the springs from what looks to be a binder that's been placed around the pelvis. And one of the things I want you to really come away with this talk is the appropriate positioning of binders. And so this binder is actually in a pretty good position. It's right at the greater trochanters on both sides. closing down the pelvic volume nicely, although you still have that residual displacement of the left hemipelvis. So these are bad actors as well. We always worry about these from a vascular and neurologic injury standpoint. You can also have combined injuries. And so this is the patient I personally took care of that had basically disruption of every ligament in the pelvis, in addition to a right-sided acetabular fracture. And so sometimes these injuries can be quite complex. Even if they're quite complex like this, the goal is always to just close down the volume of the pelvis, decrease the space available for bleeding when you're treating these patients acutely. So again, just to review, these are the bad actors. So we have the anterior posterior compression type 2 and 3. The more the pelvis opens up in the front, the more we worry about those people from a hemodynamic standpoint. And then the really bad lateral compression pelvic injuries that tend to externally rotate the contralateral side of the pelvis, and then the vertical shear. These are the bad actors, the ones that we really worry about from an injury standpoint. So the first thing you want to think about when these patients come in or when you're seeing them in the field is you always want to do an exam. Sometimes things can be a little bit chaotic, especially if these patients are critically ill and injured when they show up. But you always want to do a quick visual, manual, digital exam. Do a vaginal exam, do a rectal exam, look for bleeding, look at the perineum, look at the groin, look for any evidence of obvious deformity. You're looking for open wounds anywhere. Even the smallest wound can be significant, so always pay attention to that. Any contusions, abrasions, any degloving type injuries, old scars, any tubes or ports, and then also you always want to get a pulse exam on these patients. Make sure they have pulses distally. Sometimes you can't get a good neurological exam, but that's not something that you would necessarily do anything acutely about. The pulses are critical, so always get good pulses. So where I trained down in Texas, I trained with Dr. Chip Rout. He's probably operated on and taken care of more pelvic ring injuries than anybody in the world. And they had this saying that he would often give in talks as far as how to understand the treatment algorithm for taking care of these patients. And we'll go through this a little bit, but it's basically pack them, wrap them, warm them, fill them, squirt them, divert them, and then fix them, which is the part that we really like to do there at the end. So we'll go through those a little bit. So our patient presented. This is the initial patient I presented with the open book pelvic ring injury. She also had an open wound in her left groin that you can see here. And so the question is, what do we want to do with that? So we found that on exam. So we have an open pelvic ring injury. We want to think about packing that. And I think the important thing to remember anytime you're going to pack a wound in the pelvis is pack it with one thing. So you don't want to put a bunch of 4x4s inside a wound of a pelvis. You want to use something like a Curlex. And if it's a giant wound, a big open wound, tie 2 Curlexes together. Just make sure whatever you put inside that wound, there's only one of them there, because the person that puts it in is very rarely the person that takes it out. And it's often us in the operating room. And we don't know how many of those things you put in there unless you put one. So always just put one thing, use a Curlex. I think that's probably the easiest thing to do. Again, you're trying to just tamp out any obvious bleeding and help with the patient's hemodynamic status. So these are volume expanding pelvic ring injuries, these anterior posterior compression pelvic ring injuries. Again, these are the bad actors. And there's different ways to describe the morphology of the inner aspect of the pelvis. Some people say it's a sphere, a cone, a cylinder. I don't think it's necessarily important to delineate exactly what it is. It's probably closer to a sphere than anything. But the important thing to notice is that when you think about the volume of any of these things, 2 of them increase by the rate of the square of the radius, while the other one is by the cube of the radius. And so any expansion of the radius in relation to the inner aspect of the pelvis significantly increases the volume, which just allows there to be more space for blood to accumulate, whether it be venous or arterial in nature. So just think about that. Any way you can close down that volume of the pelvis is going to be better off for the patient. Increased volume equals decreased vascular compression and increased room for bleeding. So just remember that. So what do we want to do when we have an open book pelvic ring injury, an APC pelvic ring injury? We want to think about closing the pelvis down. Now, if you look at these 2 images, if you put on a binder before we're taking care of these patients before, what you can notice is this binder is a little bit high on the left-hand side. So I've got an arrow there showing how much lower this binder needs to be. You can see a femoral line in the right leg on that patient, but this binder is way too high and it's not really having any effect at all. And then you can look at the x-ray On the right-hand side, you can see the springs. Compare that to the image we saw earlier. You see the springs up above the iliac crest for the binder, which tells you it's not really doing anything. These binders have to be centered along or right around the greater trocaners of the femurs bilaterally in order to exert their effect. So make sure that these binders are nice and low in order to get good compression of the pelvis. Unless something's changed recently, these are the binders that we previously had down in the emergency department. Again, I don't have any financial disclosures in relation to these binders. It's just the ones that I've seen before. Any brand of binder will work. This just shows a good picture as far as where this binder should be on the pelvis. And this binder could even be a little bit lower. What I would say in general is you want to think about the center of the binder being right around the genitals. If it's in that area, that means you're low enough. You typically want to be a little bit lower than you even think you need to be in order to get these in the right position. The other thing you can use is a sheet. Now, what I'll say is a lot of times it'll be our orthopedic team putting these on. They can be a little bit tricky to put on. You usually need 2 people, but they're a little bit more soft tissue friendly than binders, especially the ones that are a little bit narrower. And they also give you some the ability to do some extra things, which I'll show you in the next picture. So the thing with the sheet is you can keep the compression, but you can also cut access points in the sheet. So you can access the femoral artery. You can get to the anterior iliac spine on both sides through holes if you need to put an X-fix on the front of the pelvis. You can get access for iliosacral or transsacral screw fixation in the back. So sheets can be very helpful. And again, they're also a lot more soft tissue friendly than binders. And anytime we put a binder on, a lot of times people ask, well, how long do we leave the binder on? When do we adjust it? When do we take it off? I think if it's a very, very severe pelvic ring injury, you're going to need some sort of compression that stays on until these patients get operatively stabilized with fixation. If it's a not so bad pelvic ring injury, it's probably okay to take the binder off. Usually we'll try to transition patients out of binders within about 24 hours or so and get them in a sheet if they're going to need prolonged compression up in the ICU. We go back to our patient. This is her open book pelvic ring injury. So we pack the wound, we get that packed, and then we put the binder on. And you can see the binder's in a really nice position here. You can see the clips of the binders right in line with the greater trochanters, right over the symphysis of the pelvis, and really closes down the volume of the pelvis nicely and puts this patient in a much more stable position from being able to be resuscitated and decreasing her risk of decompensation. Labs on this patient now are lactate of 3.5. She's hemodynamically stable, has a hemoglobin of 9.0, and she remains awake and talking, which is obviously good for her. One thing to remember as we look at this other patient who's a 39-year-old male that was involved in a motorcycle collision, people can come in with binders in place. And so this patient came into the trauma bay 1, had a binder on when he hit the door, got his initial pelvic x-rays, initial AP pelvis in a binder, which is in an excellent location. You can see the binder is centered right over the greater trochanters, right over the symphysis. And I ask here on the top left corner, what do you see? Well, you don't see anything. The pelvis looks normal. The bladder looks normal. The pelvis looks normal. I don't see any injury on this radiograph. Well, what happens is if you undo the binder, you can now reveal the pelvic ring injury that was being masked by the binder. So anytime somebody presents with a binder in place, you always want to release the binder and get an AP pelvis just to kind of get a sense of, is there an underlying pelvic ring injury here, or was the binder just applied as a precautionary measure in an otherwise decompensating patient? So always keep that in mind. Binders can hide injuries. So now we want to think about what's next. So we got the binder on. The pelvis is nicely reduced. It's compressed. So now we want to think about resuscitation. So you have to ask your question, is the patient hemodynamically stable? If so, you just continue to monitor her, give her blood products as needed, and give her supportive care in preparation for elective stabilization in the operating room. If she's not hemodynamically stable, you want to ask yourself the question, was the pelvis reduced? And anytime you put a binder on or adjust a binder, or transition from a binder to a sheet, you want to get an x-ray. So get an AP pelvis, make sure the pelvis is reduced in the way that you want it to be reduced for the resuscitation of the patient. So if the pelvis is not reduced, or it could be better reduced, you reapply the binder, readjust the binder, tighten it, retighten the sheet, and then get another x-ray, and then make sure that the pelvis is then reduced. If the pelvis is reduced and the patient remains hemodynamically unstable, you want to think about other non-pelvic bleeding sources. So if there are other bleeding sources, maybe the patient has blood in their abdomen, then they may need to go for a laparotomy, or maybe need to go for angiography for non-pelvic bleeding sources. If there aren't any other non-pelvic bleeding sources, or let's say there's a blush on the CT scan from an artery inside the pelvis, then the patient may need to go to pelvic angiography, or in some centers, a patient may actually need pelvic packing depending on their access to angiography. We'll talk about pelvic packing a little bit later, but that's usually reserved for centers that don't have access or immediate access to pelvic angiography. It's not used all that often. So the next steps for this patient, we want to think about warming them up, which is self-explanatory. Fill them up with blood products, squirt them, which is angiography if needed, divert them, and this is for colostomy, is usually reserved for anybody with an open pelvic ring injury that has a bad wound in the perineum, in order to try to do local wound care and keep that wound clean and give it the best chance to heal without infection. Pretty rare that happens, but it does happen occasionally. Then we end up fixing these down the line once the patient has been medically optimized and cleared by the trauma service. So when you think about filling these patients up, you want to think about aggressive resuscitation. So we think about the difference between whole blood, which is on the left, and then a 1-to-1-to-1 transfusion of packed red blood cells, FFP, and platelets. So the whole blood has a higher hemoglobin content, has more platelets, has improved clotting ability with increased fibrinogen and better clotting factors, has better platelet aggregation, and also has easier storage. It's more straightforward to store whole blood because they only have one storage mode, versus to store the 1-to-1-to-1 transfusion components, as there are 3 different storage modes for those. And so the whole blood is preferred in these patients. It doesn't always happen that way for transfusion purposes, but if you don't have whole blood, the 1-to-1-to-1 transfusion is the way to go. You want to try to limit crystalloid in patients that come in with these bad pelvic ring injuries that are bleeding. These patients are bleeding and they need blood. So just keep that in mind. When we think about angiography, that's the squirtum part of the algorithm. If these patients continue to bleed, and you can see even in the patient here on the left, they've got multiple laps in the image here that you can see. As these patients continue to bleed, even with the pelvis closed down, a lot of times they'll benefit from going to angiography to see if there's a bleeding source, a small arterial bleeding source that can be embolized in the IR suite to help control some of that bleeding. And a lot of times this happens after a patient maybe goes to the ICU, has had a binder put in place, but has a continued drift in hemoglobin without a clear source. Sometimes you can see these blushes on CT scan, and when they initially come in, a lot of times you can only see them when they go to angiography for embolization. So this is what happens at our center. We have pretty immediate access to angiography, so this is most of our patients will go down for this if they need it. The preperitoneal packing is not something that we do very often in our institution. A lot of times these patients, if they do get this, will end up being in the operating room for some other intra-abdominal source of bleeding. When you do think about pelvic packing, you want to think about basically putting compression on the vessels that are in the inner aspect of the pelvis. You're putting the packing extraperitoneal between the bladder and the pelvic brim to try to add compression to the bleeding veins. Again, better for veins than arterial bleeding, but bleeding veins and venous structures around the inner aspect of the pelvis. And this is what that looks like in real time. This is just a low fan instill incision. There to the left, you can see the pelvic sidewall. To the right, you can see the peritoneum and probably part of the bladder, pushing the bladder back out of the way and sticking laps back into that area to just give some compression to those venous structures to try to limit the ongoing bleeding from that area. And the one thing to remember anytime you're doing pelvic packing is you have to have a stable pelvis to do this. It doesn't really do a lot of good to have a pelvic ring injury like I showed in our patient earlier that we'll come back to, where it's widely open. It's a widely open book pelvic ring injury to put packing in there without something to pack against. So you want a pelvis that's closed down from a volume perspective, and then have something to be able to push against with the packing, which gives that nice compression. So you must have a stable pelvis to compress against when you think about doing intrapelvic packing. REBOA, or what's also known as resuscitative endovascular balloon occlusion of the aorta, was previously, I think, used a little bit more than it is now. I have not seen this used recently. Maybe some of the trauma surgeons can chime in after I finish my talk, just as far as its use these days. But this was fraught with a lot of complications. There are a lot of patients that had vascular issues distal to the inflated balloon in the aorta. There are patients that are documented as having lost limbs, required amputations. This is kind of a heroic type situation if patients are exsanguinating, either in the pelvis or down in the lower limbs. And so this is not used as often as it used to be, just because of the complication profile for REBOA. So just keep it in mind. It is out there, but there may be some centers that use it more than others. So we go back to our case. The question with this that it often gets brought up, especially if the patient's going to the operating room for something else, is would an external fixator be helpful here? We put these patients in binders, and oftentimes you can think about putting them in an external fixator, which takes compression off of the skin and prevents you from having skin issues. But does it really help in some of these situations? And I would say it depends. And I'll show you what it looked like in this case. So this lady this is again the same case that we've been going over from the very beginning of the lecture. This patient was initially taken and put it in an external fixator in her anterior ring and had an IND just for her open fracture. But as you can see, the problem with this is that there's no hinge in the back of the pelvis. And so for an anterior external fixator to be effective, there has to be a posterior hinge. Now that posterior hinge can either be ligamentous structures, it can be the posterior sacroiliac joint ligaments, or it could be fixation. So we can put a screw in the back of the pelvis across the SI joint, and then that gives us the hinge to then compress the front of the pelvis together with an anterior X-fix. And we can always come back if we do that and revise the fixation later if needed and do the definitive fixation once the patient's more stable. But this is one of the reasons why we don't often put X-fixes on in severe pelvic ring injuries with complete ligamentous disruption, is because they don't really control the pelvis all that well with just a single pin like that. And you can see there on the right side, this is the image that we had with the patient in the binder prior to thinking about putting an X-fix on. And you can see the pelvis is much better reduced in the binder. As long as it's in a good location, the volume's reduced better. The right SI joint looks more reduced. It looks a little bit more congruent than on the right side. So a lot of times these patients are better off just from a reduction standpoint in a binder or a sheet than they are in an isolated anterior X-fix. So this patient comes back after we fix her, take her to the operating room. Again, she did well from a resuscitative standpoint. We took her to the operating room. We fixed her, fixed the back of her pelvic ring, put screws there to reduce and fix her SI joints, and then also a combination of screws and plates to fix her anterior ring. And this is her 3-month follow-up x-rays. She has a little bit of right buttock pain when sitting, but is otherwise doing well. As weight bearing is tolerated with minimal discomfort. So a few final thoughts for these severe pelvic ring injuries, and just kind of review what we've talked about. These can be life-threatening injuries. Now, again, they occur on a spectrum. They can be as simple as what you see here on the right with a slightly open pubic symphysis that probably doesn't have any vascular compromise and is an otherwise stable patient, to something widely open like the patient we talked about in this lecture. So you want to just understand the spectrum of injury, understand the energy it takes to impart a significant disruption to the pelvic ring, and manage these patients appropriately. So you want to pack open wounds. Again, pack them with a single Kerlix, or if it's a big wound, tie 2 Kerlixes together. Don't put multiple laps in there. Don't put multiple combat gauze in there. Again, we don't know how many go into those wounds, and we're usually the ones taking them out. You want to focus on stopping ongoing bleeding, whether that be with angiography or pelvic packing. Again, if you're going to pack the pelvis, I don't think at our institution, I don't know of anybody that are taking patients to the operating room just to pack the pelvis, but it may be done in conjunction with another procedure. Reduce the volume. These injuries are all about just decreasing the volume of the pelvis, providing compression to the vascular structures inside the pelvis, stop the venous bleeding. If it's arterial bleeding, a lot of times they'll need angiography in order to get coil embolization of the small vessels that are bleeding. So just keep that in mind. Resuscitate these patients with whole blood. Limit the crystalloid that you give them. You want to keep them warm, and then you want to, once you kind of get them in a good situation, a lot of times these patients will be in the ICU. You want to just monitor the patients, make sure they're not decompensating, make sure their hemoglobin's not drifting, make sure their lactate is clearing. All of these things are going to be important for us as the orthopedic team to be able to take these patients to the operating room in a timely fashion and operatively fix and stabilize their pelvic ring. That's all I got. Thank you. Take any questions anybody has.
Travel Capital One has a reward.
There was one question in the chat box from overseas, actually in Turkey, I believe. I'm a special forces medic. My question is, in high energy blast injuries, for example, IEDs, landmines, artillery strikes resulting in pelvic ring fractures, how do you balance time critical hemorrhage control with definitive pelvic stabilization in the military operational environment, specifically in settings characterized by prolonged evacuation times, drone threats, and limited resources? Which stabilization and resuscitation strategies should be prioritized? I think we're seeing more and more frequently, instead of the golden hour, we're seeing 12-hour plus evacuation times is what he's getting at.
Yeah, good question. And again, thank you for your service. I have not been in those type of situations, and so I'll give you my perspective, having not been in that specific scenario. Obviously, the bleeding is going to be the big thing. Your goal in the initial resuscitation of these patients, you're not worried really about infection. I mean, we can obviously deal with that down the line, but the goal is to keep these patients alive, and you have to do whatever you can possibly do in the moment to limit bleeding, limit hemorrhage. And it all comes down to packing, wrapping, compressing, all of those things to try to limit bleeding. Now, if you have big open exposed wounds, you may have to get a little bit creative with your ability to pack those wounds with whatever resources you have, combat gauze, Curlexes, whatever you have. Just pressure, compression, decrease the volume of the pelvis. Those are your friends. And outside of that, a lot of times you just have to leave that stuff in place until the patients can get to somewhere where they can get a more thorough evaluation and a more make it to an operating room where the setting is going to be a little bit more controlled in order to better address some of these severe injuries. And so once you get that hemorrhage control, keep all that stuff in place as best you can.
That's a great answer to that. We got some questions in the audience. I would just dovetail with that, Dr. Phelps, for all of our EMS providers on the call. It's obviously you're not under fire, but still similar concept. So we never ever would fault any EMS provider for putting a binder or wrapping a pelvis when they're bringing somebody in. If you even suspect a pelvic fracture in somebody that's unstable, my rule is that any motorcycle crash gets a pelvis wrapped until we prove they don't have a pelvic fracture. So you're never going to hurt anything by putting a binder on, and you may miss something if you don't. So just sort of to finish that thought. Dr. Lauer, your hand was up. You have a comment or question?
Hey, Dr. Phelps, great talk. Two questions for you. The first one is, in the setting of a bad pelvic fracture and either severe acetabular fracture or a hip dislocation, what do you do about the binder there? And then the other question that I had was, do you know of any data about differences in like neurologic sexual complications down the road from angioembolization of the pelvis versus preperitoneal packing, or do you think it's mainly related to the injury itself and not necessarily the resuscitative strategy?
Good questions, and I just want to comment on something Dr. Green said real quick, then I'll get to yours, Dr. Lauer. A lot of people worry about putting binders on lateral compression pelvic ring injuries. The chances of you putting a binder on and decreasing the volume of the pelvis is high. Decreasing it past physiological levels is high, but a lot of people worry about causing additional trauma if you over compress the pelvis. Really sure why this thing is going backwards. If you over compress the pelvis, the reality is like that's not the case. It would be extremely rare to over compress the pelvis and cause additional injury. The binder is not going to cause the same level of traumatic disruption as a car wreck or a motorcycle wreck would cause. And so if you put a binder on a lateral compression pelvic ring injury, it's not a big deal. So don't worry too much about that. To Dr. Lauer's question, in the setting of an acetabular fracture, if they have a concomitant pelvic ring injury, the bleeding situation takes priority. If they have a hip dislocation, let's say they have a posterior hip dislocation, in an ideal situation, we would reduce the hip and then put the binder on. Sometimes with some of these acetabular fractures, the hip dislocates inside the pelvis. If that is associated with a severe open book type APC pelvic ring injury, then you prioritize the pelvic ring injury and close everything down and let us worry about the hip. Bleeding takes priority, closing the volume takes priority. We can always, once we get involved, can make decisions based on what the status of the hip is in regards to what it needs in combination with the pelvic ring injury. For the sexual and urinary dysfunction, I just thought I've not seen any data as far as angiography in regards to that to know if that is a contributing factor. What I will say is a lot of these patients that I treat, whether they have angiography or not, come in with urogenital dysfunction of some type. I think it a lot of times will affect males more than females. A lot of these patients will have erectile dysfunction. We'll end up sending them to urology. I think studies have shown, and my gestalt is also, that it's to do with the actual injury itself and at the time of the disruption. There is a lot of soft tissue injury in the front of the pelvis. I think that's probably the primary driver for this rather than angiography.
Got a question from our conference room. Can't see who that is, but I see a hand up in our sticky conference room.
Yeah, this is Alex Merkel. I'm one of the military PAs with the Special Operations Surgical Team, and I really appreciate the question about the downrange environment. So for those who are not familiar, there's a little bit of background, and then I've got a question. When you see these IED blasts that have bilateral lower extremity amputations, there's actually a 60% mortality rate with that, which scares the pants out of all of us, I think, because it ends up essentially ripping both those legs apart and splitting the pelvis open for catastrophic bleeding, as well as huge injury burden for genitourinary. And so my question to you is, thinking more about that austere practice location, my civilian practice is a level 3 trauma center in Montana, where we're 8 hours to the nearest level 1 trauma center. We often use this preperitoneal packing. So just kind of thinking about outside the level 1 trauma center where we have all the bells and whistles, do you have any other recommendations on approach to initial workup or management for those student learners here that are maybe not going to be in a level 1 trauma center for their practice going forward? And thanks again for a great presentation. Over.
Are you saying this in regards of hemorrhage control, bleeding control in these patients if they were to present to like a center where angiography is not available? Is that what you're referring to?
Yeah, absolutely. As everybody knows, we've got all the opportunities for the specialists and all the special toys here, but as our special operations surgical team looks at practicing in the downrange environment, the CT scanner is our hands, and we've got a general surgeon, hopefully a board certified trauma critical care surgeon. But yeah, we don't have either interventional radiology or even angiography available, even in a lot of the US rural practice environments that we may find ourselves in the future. And would love any tips and tricks you could share to optimize patient care. Thanks. Over.
Yeah, what I would say is if you're in that kind of situation, and let's say the patient's crashing, you take them to the operating room, you're doing a laparotomy, or they're crashing and you don't have a good explanation for it. Maybe they don't have blood in the abdomen. You think it's coming from the pelvis. I don't think there's any issue if you don't have the resources to taking patients to the operating room and doing the preperitoneal packing. The one thing I would say is if you're going to do it, put a lot of packing in below the pelvic brim, along the pelvic brim, on both sides usually. of the pelvis, unless one side is just completely not disrupted. So put a lot of packing in, make sure it's radio opaque, make sure whatever you use, we can see on x-ray. And then when you're done with the packing and close, make sure you wrap the pelvis back up. So you want to put a binder back on the pelvis. If you have an APC type pelvic ring injury, after you do the packing, don't just rely on the packing to help stabilize the clots in these patients. And then once they get stabilized, once you've got the hemorrhage under control, then you can always ship these patients to level 1, level 2 trauma center for more definitive management. But again, just make sure whatever you use is radio opaque. You can see it on x-ray. That way it's well documented how many of whatever you used and put in the operating room. That way we know exactly how many to take out. And it's probably good to have that direct, if you're transferring these patients, have that direct conversation with the surgeon that's going to be taking care of the patient. Tell them how many laps you put in there. That way they know exactly how many to take out. But again, I think the important thing is you still want to think about decreasing the volume of the pelvis. And so if you're going to do the preperitoneal packing, wrap the pelvis back up and compress it.
That's a great point. We're starting to get a little bit probably out of bounds for the scope of this discussion, but the description of preperitoneal packing originally has, I think it was like 3 packs on either side and 3 in the middle. You can get about 30 laparotomy pads in that space. But the point is, as Dr. Phelps said, no matter what you put in there, you still want to compress that pelvis when you're done, you're trying to create tamponade. So, and back to something you said, Kevin, when we do preperitoneal packing, which is very rare in our center because we have access to angio and everything else we need, but in discussion of these austere environment situations, obviously that's different. We are generally doing it because we're already in the abdomen, or we need to be in the operating room doing something else. It's very rare that we would go straight up in a level 1 center to the operating room specifically to do a preperitoneal packing, but still a great skill to have in your pocket if you find yourself needing it. Scott.
Hey, Dr. Phelps, I see quite a few other hospitals on this call, both trauma centers and non-trauma centers, as well as multiple pre-hospital partners. Is there anything that we do either pre-hospital or in our outside hospitals prior to transfer that you would recommend us not doing? Are we adding binders too often? Are we doing any sort of anything that you don't like or is complicating what you have to do?
A good question. And I think I'll just echo what Dr. Green said earlier. I don't think it hurts anybody to put a binder on. And so if you put a binder on somebody that didn't need a binder, it's not a big deal. We can take that binder off when they get to the ED and we get an AP pelvis and decide that they don't need it. I think it's better to have a binder and not need it than to need a binder and not have it. And so I don't think that's an issue at all. I think, again, it all comes down to bleeding control and hemorrhage control, packing wounds, wrapping wounds. Again, if this is a little bit different than trauma, but if people have severe open extremity injuries and they have arterial bleeding, tourniquets, trying to keep the blood in the patient's body as best you can. But as far as that goes, I mean, obviously we can get down into the weeds a little bit with kind of more complicated injuries, with combined injuries with some hip dislocations or acetabular fractures and those type of things. But in my mind, I don't think there's ever a time where it's wrong to put a binder on somebody if you're concerned about a pelvic ring injury that's contributing to ongoing hemorrhage in a patient.
I would add one more thing to that because we're talking about venous bleeding, just make sure that we're getting IV access somewhere above the diaphragm. It's not always great to get IV access in a femoral vein and dump a few units of blood into their bleeding pelvis. So generally that's not a problem, but if we're suspicious of pelvic trauma, let's make sure we have IV access above the diaphragm, upper extremities or otherwise. Dr. Watson.
Hey there. So my question.
We make an international call if we have somebody from South Carolina calling in.
Yeah, exactly. I was going to say, now it's exciting. So in regards to hemodynamics, I think most of us feel strongly about erring on the side of, even if they're just slightly tachycardic, if we know that we've got a pelvic fracture, binder is kind of our go-to move. We've had a couple of instances on the rare occasion where we have an open book pelvis and then someone's becoming hypoxic without any chest trauma, something like that. So is there been any updates, any role, anything that we need to be thinking about from a fat emboli syndrome, especially with stabilization? I've had some of my recent ortho people with talking about previous literature really supporting, not using some of these measures. And I'm just curious, any updates on that?
Not using which specific measures, like just the pelvic binders, or
Yeah. So like I'm a level 3 becoming a level 2, but I
Mhm.
don't have anyone currently doing XFix. So let's say, I'm transferring those patients up to Dr. Green and his team. So
Yeah.
if we have a patient who is all of a sudden decompensating and I don't have another reason as to why, are we still using binders, or what other fixation should we be using? Because a packing is not really going to do anything in that regard.
Yeah, I mean, if it's decompensation from a bleeding perspective, the compression and the binders are going to be your friend. I'm not aware of any literature that talks about fat emboli syndrome from an APC or a lateral compression type pelvic ring injury. A lot of times those are a result of long bone fractures, where you get basically the marrow extravasation into the circulatory system. Could it happen? Sure. I've not seen that happen. I'm not aware of any situations that I've been involved in, and I've taken care of a lot of these patients, where we were concerned about the binders in some way causing respiratory decompensation in the patients. What I will tell you is it's extremely rare, and by extremely rare, I would say I have not acutely put an I've not acutely put an
Oye,
anterior
¿por qué le
pelvic
quito el
X.
palco? Necesito una explicación.
I have not acutely put an anterior pelvic X fix on a patient at the time that they've come into the hospital since I've been in practice. And we are a very high volume center here and take care of a lot of these patients. And so it would be extremely rare to need to put a anterior X fix on a patient initially. We treat almost all these patients. Either we go binders initially, if they're going to be in binders for longer than 24 hours, maybe they need some ongoing resuscitation in the ICU. We'll end up transitioning them to a sheet just for soft tissue, just to avoid soft tissue compromise, because binders can cause some skin necrosis if there's pressure in certain areas, especially in obese patients. So we always want to keep that in mind. If we start to get to the kind of the 2 to 3 day range, and these patients are perking up a little bit to the point where they can have stabilization, sometimes we'll take them and do some sort of minimal internal fixation in the operating room to see how close we can get things, knowing that we could have to come back later for more definitive fixation or revision fixation if it's not adequate. But just to get them out of a sheet, that way we more so avoid the skin issues than anything else.
Thank you.
Other questions or comments? I'm sitting on one that I hesitate to bring up, Dr. Phelps, but you did mention the Reboa. So I'm not sure if I'm going to drive the final nail in the coffin or just wrap it up real tightly where it's tough to open. But I know we have some Reboa enthusiasts on the call. I will tell you that the use of balloon occlusion of the aorta is probably relegated only to those centers who have been involved in developing it and have a real quick trigger and facile use of it. If you don't use it very often, it does nothing but delay things. They can be difficult to place in a hypotensive patient. There's all kinds of challenges with it. So while it's a theoretical and scientifically fairly sound device, you're not going to see that used very often in general practice, and that includes most major trauma centers in the country. So I understand that's a controversial statement for me to make, but when you said you really haven't seen Reboa used very much, I made the only slightly sarcastic comment in the chat that you're not going to see it anytime soon either. So we do use it in other circumstances. It's not completely dead, but it would be pretty rare for you to run into that. And it might have more use, just like what Alex was talking about in a level 3 with the prolonged transfer time, if you're facile with it and you can use it as a partial occlusion or something like that. But I'll just sort of leave that one out there in the universe for further discussion. Other comments or questions? I thought for sure Dr. Lauer would come back with a comment about the Rebola on that one, but
Nobody took the bait.
uh, if there aren't any other comments or questions, again, thank you very much for a really informative talk. There's another comment from Haiti. That's a tribute to Scott and his PR skills and making sure we advertise this. Thanks everybody for being flexible with the time change. I hope this worked. We have a great crowd. But Dr. Phelps, thanks so much. Great talk, really informative, and I think everybody got a lot out of it. So if there are no other comments, everybody have a great rest of your Tuesday and get ready for a little winter storm trauma this weekend, huh? All right.
Thank you. I really
Thanks everybody
appreciate
for
it.
joining.
Thank you.